can't click this, that, the other, whatever. So the more interactive, the better. No formalities. We are still waiting for people to come and join. So while we do that, everyone's going to say hi to each other and pop their names into the chat. I can't multitask, so I will speak first, then I'll pop myself into the chat, and then I'll just sort of throw over to someone. And then if you can pop yourself in the chat so that other people coming in can get to know each other. Again, put your formalities away. This is really about just getting to know this awesome tool, which we all love. Okay, so I'm Eba from the Health Cluster, Global Health Cluster, and yeah, that's it. Helped develop this tool. I'm going to hand over to Veronique as well.
Hi everyone, I'm Veronique with the Health Cluster, Global Health Cluster Secretariat. You love familiar names, and yeah, I'll be supporting this workshop. Thanks.
Who are you handing over to?
I'll hand over to Jura. John over at Jura.
Hi, everybody. This is John Fogarty. I'm the lead for primary care services in the Integrated Health Services Department at headquarters for WHO. And with me is my colleague, Dr. Parisa Kamali.
Nice to meet you. I'm a consultant working with the team and on SPDI. Nice to meet you all.
You have to ping pong. Who are you going to throw the ball to?
I'm going to pass to Lydia.
Great. Who's that?
Lydia De
That's
Pascal.
me.
Hi, great. Welcome.
This is Lydia De Pascal, a medical advisor for Intersos for West Africa and Eastern Central Africa regions.
Excellent. Who are you going to
And
do? Yeah.
I pass the ball to Parisa Kamali.
Parisa Kamali.
You get
Oh,
this.
sorry. John just introduced me.
You're double.
And I will pass the ball to George Miranda.
Great.
Great. Jorge Miranda, I'm associate at the regional office of IOM in Panama. It's a new office, and we are part of the Migration Health Division in Geneva. So we are covering the Americas and the Caribbean region in
great.
health and migration.
Great. Fabulous. I'm gonna, who are you handing the ball to? Maybe Gillian. Oh, you're next on my line next to Jorge.
Thanks, Eva. Hi, everybody. My name is Gillian McKay. I'm the Senior Humanitarian Health Research Advisor for ELRA's Research Health and Humanitarian Crises Program. Lovely to see you all.
Great.
Ping pong too, don't I? Alison.
Yep. Hi, everyone. I'm Alison Prather. I'm a Senior Technical Advisor on our Health Equity and Rights team, supporting our health and emergency responses. And I joined, apologies, a few minutes late. Prim? Passing to Prim. They have not gone.
Hi everyone. My name is Prem. I'm an emergency physician here representing the Harvard Humanitarian Initiative Health Systems.
Great. Remember to pop your name in the chat, please. Prem, who are you handing the ball to?
I'm not sure who hasn't gone. Sorry, I joined a couple minutes late, but has David gone?
No, good choice. He's
Hi, everyone.
brooding.
Yeah, perfect. I'm David. Nice to meet everyone. I'm the director of the Children in Crisis Humanitarian Program at the Boston Children's Global Health Program and Harvard Humanitarian Initiative. Thanks for being here. And then I'll pop it over to Amy Cannon.
Fabulous.
Hi, everyone. I'm Amy Cannon. I am a Senior Technical Maternal Newborn Health Advisor with JPICO. Excited to be here. I will pop it over to Sienna.
Did Sienna already go?
No.
No, go great. Sienna, go. Fabulous.
Yeah, thanks, Amy. Hi, everyone. My name is Sienna Greenwell. I'm also with JPICO. I'm a humanitarian project officer. I'm based in Baltimore, Maryland in the US. I'm very happy to be here. And I will turn it over to Fernando.
Great. Fernando Fernandez. Perfect.
Well, thank you. And my name is Fernando Fernandez. I'm the health focal point for West Africa for DG ECHO, based in Senegal, in Dakar. And I honestly, I think I lost track of everybody who already spoke, but
Oh, you're gonna
I
test
will
me.
try with Sin Asato.
Hi.
Good.
Hi, everybody.
Hi, Shin.
Oh, sorry. Okay. I work in the IOM regional office in Bangkok as a migration health officer. Nice to see you again. Sorry, my camera cannot tell. Sorry.
No problem. Solange, have you been yet? You may have, I don't know.
No, not yet. Good afternoon to everyone. I'm the medical advisor at Intersource in charge for the Regional Office of Emergency and Regional Office of Middle East. And I lost the track as well. I will try with the Cecilia Lopez.
Oh, yeah, good one.
Nuriel.
Cecilia? We can't hear you, but it'd be great to introduce yourself because my mind is blank. I've totally forgotten which partner you are, even though I know. Should know.
You hear me now? Yes.
Yes.
Hi, my name is Cecilia Lopez. I am the Global Health Advisor for Medical Team International.
Yes.
In HQ.
That's it, of course. Gabriele, we definitely haven't heard from you, I think.
Yeah. Hello, everyone. My name is Gabriele Rossi, and I'm a health and nutrition advisor for Medera, the global office. And I pass the ball to Andrew Boyd, the CDC.
Okay, and just a reminder, everyone, to pop your names in the chat, and if you can, go on camera.
Hi, good morning, good afternoon. This is Andy Boyd with the Global Public Health Emergency Branch at CDC in the US. Thanks.
Hi, Andy. I think we should... Prabhu, you haven't gone.
Hi, everyone. My name is Prabhu. I'm the Humanitarian Medical Advisor for AmeriCares, which is a US-based NGO. I will pass it on to Parissa Kamali.
She's already been, actually, so you lose.
Hello.
So, but Ilham's free. She's joining in. Go ahead, Ilham.
Yeah. So, hi everyone. This is Ilham with WHO. I'm a senior emergency officer with the Humanitarian Unit, aka FCV, with WHO. Over.
Great, Ilham. If you can get your camera on, that'd be awesome. Tam Fetters.
Yes. Hi, everyone. I'm a senior research scientist at IPAS. I lead our research in humanitarian settings. I am currently on holiday in Mexico, so I'm not going to turn my camera on and torture all of you.
Oh God, make us all jealous.
Thank you.
Thank you for joining. That is a lot of commitment. And look at that, Neha has just come on camera. So fabulous timing. Over to you.
Hi, everyone. I am Neha Mishra. I'm joining in virtually. I am with the Clinical Services and Systems team in the Integrated Health Department, working closely with John. Good to see you all.
Great. Okay, this is where I try and share my screen and then I lose track of everything. Right, so just to be clear, that was actually scheduled into this 2-hour workshop because we've really got to become very comfortable with each other. We want this to be an open Q&A session. So at any point you have a question, if you raise your hand, I will not notice. Just speak, that's fine. And that's probably the best way to go. Of course, you can be polite. Someone will be monitoring the hands up, hands down thing, but just feel free to go off on mic, off mute, yeah, just let's make this as interactive and as informal as possible. I'm trying to change thingy bobs. Right, so in the squad today, we have Team H3, which is myself. Andre, who isn't here yet, many of you know him, he's within the WHO HEI department. He will be joining in 20 minutes or so. John, you've met, and Nurian, who you've also met. And we were some of the key people who have taken through this and developed this H3 alongside a whole bunch of you. So I'm hoping many of you have already seen this as was shared, but the guidance, which isn't the tool that we're going to be going through for this, was finally released in July this year. And yeah, it's just the guidance around what the H3 is. I'm just going to walk through very quickly some of the background and what the point of H3 is, and then we'll get to the play bit. So bear with the theory. So why are we doing this is because of the World Humanitarian Summit. Many organizations made a commitment to defining a minimum package of services or a essential package of health of services. And this was cross-sectoral. So it wasn't just a grand bargain that happened.
Eva, you're muted.
Someone muted me, wasn't me. John, I blame you. You're bored of me already. Okay, so many of our organizations have made commitments around a minimum package of health services, and that's key for AAP, because basically, it doesn't matter where you are in the world, if you're affected by a crisis, you have the right to know what services you are entitled to receive. We know in some contexts it's more than others, there's huge inequity, but at the basic, there should be a minimum set of services that any person who's in crisis should receive. Thankfully, and because of John and his colleagues, UHC was also obviously comes from the SDGs, but we have the UHC compendium that was already shared with you. It's a compendium and listed actions on services or actions to take to provide services. And so it's in line with that. It's actually a subset of that we've used. Because of this, it's actually a fabulous entry point for HDN, because Ministries of Health will be using the UHC compendium. And as such, that is their denominator, let's say. And from that, we can say, okay, this is your package. As humanitarian responders and with humanitarian financing, we can do X, Y, Z. We've tried to develop quite a few position papers on this or define this since the World Humanitarian Summit. You can see those papers there, but it really wasn't until the compendium was launched in December 2020 that we had the opportunity to do this really well. And so that changed the landscape and the ability for us to define this. So the H3 is a minimum set of services, a prioritized set from that compendium. And the difference around this is, and many of you already know, it's not about a package of services, it's what services should be provided at each service delivery platform. What is the minimum place where these services should be offered? Should it be all community health workers that do antenatal care? Can we be accountable for that? It's not a should, but what can we really do? It's not aspirational. It's a real fact. It's a real hard check on this is what we can be accountable to deliver at a minimum in any crisis anywhere. Of course, it'll be contextualized at country level. It may be very, very different, but that is the point of the H3. It gives a basis of the minimums that we can all commit to. And so therefore, it's explicit for us humanitarian responders. I don't respond, I just coordinate. So for you guys, it's informed by multiple different tools and country examples. And as we said, is aligned with UHC. Compendium wasn't actually meant to be for acute emergencies, but we've seen that it's actually perhaps more useful in acute emergencies, because that is really when people come together to define, for example, in OPT, for example, in other contexts, this is what we can do given this operational context, given the insecurity, given the attrition of healthcare workers and the rapid loss, this is what we can realistically do. So it can actually be adapted for that, however you go forward. So why is it useful in general for you guys as an individual? At a minimum, it allows you to see all the different actions that are defined in UHC and what H3 has been collectively defined as. So you can then see in your setting or in your program, okay, my clinic in XYZ in South Sudan is delivering this. Compared to the H3 or even compared to the national package, this is the difference. So this is the utility for health cluster partners. For the health clusters where they are activated, obviously it helps us define collectively a health cluster package, a package that should be delivered in humanitarian response. There should be an agreement at country level to define what those services are. It's not an easy task. We've done it in a few contexts and there's some hard conversations that happens, but it allows you to define those services and what is basically your network of your different service delivery platforms and what you should be using where. And it may change subnationally. There may be insecurity, flooding, even less infrastructure, whatever those things are. It may be different at subnational level, but at least you can collectively define that. Again, it supports AAP and HDN. And for all, from this, once you have a package, and we will go through this and you'll play with this, you can see how you can export what medicines are required using WHO guidance in existing SOPs and against the existing emergency health kits. You can see what drugs are actually required to do that response, or you can plan your staffing needs around it. Thereby also, if you need training, you can see, okay, this is a minimum service that I know we can deliver now, but for something else, we may need extra training. So it helps the implementation for everyone, whether it's a health cluster or for you as an individual partner. And obviously, you'll just get better monitoring, reporting, understanding service availability. But also, because you know what services you are meant to deliver, you will thereby know what quality standards you are meant to deliver. Are you meant to do X, Y, Z, or are you, which service are you really meant to show the full package? Full, is it safe, etc., etc. So this is just the development. You'll have these slides, so I'm just kind of whiz through it. We had a core group, we did a lot of research, we did massive document review, went through loads of evidence from different countries where clusters were activated with regards to burden of disease and conditions, looked at existing packages in health clusters, we mapped it to the compendium, but importantly is this here, is that once we had a draft package, we had a consultative process with over 70 experts to help have those conversations, which were very, very hard, around which services should be provided at each level. So we didn't actually come up with it. Everyone had some tough conversations. It aligns with MISP, it aligns with, well, as much as we can, with SPHERE and the other guidance, and all of those stakeholders were involved in this process. Then there was a final review and check for cohesion, obviously, and then we launched the tool. So this is a bunch of people who helped make it. And these are all the experts who were involved in the different areas. You may have been involved already. Okay, I can't remember what this is about. Oh yes, now I remember. Okay, so the point is that the H3 helps establish priority setting criteria to determine what services are core. So this is the minimum, this is the core that you must do at a certain level, no matter what. Everyone has to do it. Everyone has to collectively agree, yes, we can do that. Conditional kind of came later, but when we first developed it, we then had extended. So these are services which could be done at whatever service delivery level if we had further training, if we had the resources, and if it was possible. And then conditional is what, I'll talk about that in a bit, actually. So these criteria around why the services were chosen is that they have to be evidence-based, they have to be time-sensitive, they need to have a high impact. This is for humanitarian response. It's not the wider package. It's for urgent life-saving care. It has to be feasible. This is a big one. By the level of healthcare workers that are there. You cannot make community health workers do what a doctor is doing and expect everyone or some community health worker to do XYZ services and package. Everyone would love a community health worker to do everything, but it's impossible unless they've got the training, you've got the numbers, etc. Equity, it needs to be equitable for that geographic area that you are working in. It has to be clinically effective, meaning that if you're doing a bundle of services, for example, for pneumonia, you need to be able to take the temperature, you need to be able to take the pulse or the respiratory rate, you need to understand if it's severe or not. But you also need to have antibiotics. And if you don't have that bundle of different interactions, that treatment of pneumonia is rendered ineffective. So it has to be clinically effective. And also with regards to the humanitarian imperative for all the different aspects of humanitarian assistance. This includes supporting people to recover from harm, meaning that there might be something which hasn't got high mortality or high morbidity, but because of the gravity and the severity of the threat or the condition, it's a priority to address in humanitarian settings, and GBV is a classic example of that. So core, conditional and extended. So core is, yes, I can do this right now. Extended is, well, actually my healthcare workers need more training, formal training. If there's something where actually healthcare workers could do with some orientation, let's say psychological first aid, you can't meet it now, but in 2 or 3 months with some orientation, actually they'd be able to provide that. And so that is when we came to country level and we started rolling out and contextualizing these and developing H3s with health clusters and partners. They actually said, this is a really pertinent service. It's a core, but we can't do it right now. But then that also allowed the prioritization of training or support that is needed. So condition was done. So these are the deliveries of healthcare. No, the service delivery platform, I can't read, that we have defined in the H3. It's a global reference package, so obviously it's completely nonsensical for most countries. Every healthcare system has different names for their tiers of healthcare. But the way we've done it is community healthcare, and that's where you have CHWs. They've had some kind of training, and they either work at a health post type setting or they do regular home visits. Outpatient is manned by nurses, is staffed by nurses, and doctors aren't usually present there, so that's the cadre of staff that we're working with there. But we've made the sort of criteria hypothetical that there are no 24-hour services there. As such, we have the birthing type facility for BMONC, a mid-tier sort of facility that essentially allows for BMONC to occur. And then we have our first level referral hospital and a second level referral hospital. And John will walk through this with you, but you will see it. You will have an action here, and you will be able to select in green your core service, and then for other services say, yeah, that's important, but it's an extended service. I can't be accountable to deliver that right now, or we collectively cannot be accountable to deliver that right now. And then grey is when it's not selected. So you'll walk through that soon. And just to say, Nurian is here from Save the Children, and she's supported by BHA. They've done a lot of research into mobile clinics and what quality of care looks like there. And that's using the WHO and the Global Health Cluster definitions and position paper on quality, using the quality toolkits we've developed. So really using those 7 paradigms. But then from that, being able to define, okay, if you are going to do a mobile clinic, what would be those services that you would deliver there. So that is in development, and we will have a round of consultations in Q1. Oh my gosh, I'm not looking at the chat. If someone's got a question, you have to tell me, you have to go off, or someone has to tell me that there's a question, because you're absolutely welcome to interrupt me. I'm nearly done, and then you'll get to the fun bit. Okay, so it's a reminder, H3 is a reference package. It's at the global level. Users can contextualize it, whether it's for you as an agency, obviously, you'll see, you can actually make it into an Excel sheet, it's not a big deal. Or, as we expect, in countries, in country clusters, define collectively, together. It should be a group effort by all health cluster partners to define what that package is that you're accountable to deliver. And so because of that, you adapt it to the health threats that you're facing. What conditions, what diseases? Have you got malaria? Have you got diabetes? Do you do dialysis? Do you not? Is there a high GBV risk or not? Likewise, you can also adapt the typology of those service delivery platforms. Is it PHCC or PHCU, basic health unit, a medical point like they have in OPT, or what? You can define that. Likewise, you also can define, according to the national guidance, on what the staffing should be at each of those levels. So as you go through that at country level, and it should be a workshop of about 3 days with all the cluster partners present, having these hard conversations, you can define what should be at each, and then have the conversations with regards to what can be delivered at each level. Oh, Andre, my heart is beating. I'm so happy. I'm just going to finish this slide and then I'll hand over to you. Andre is from WHO, who helped develop this, and we all love to hear his voice. But basically, depending on what it's like in country, if you've got higher capacity and if you've got higher resources, then obviously the standard of services or the level at which the healthcare services are provided can be much higher. But the H3 for us is what we would say is a minimum, and seriously, it's super minimum. You'll see this, you can do adaptations, adding services, deleting services, or shifting it down from, maybe it's not first referral level, maybe it's at PHC level or outpatient level, maybe it's at CHW level. So on this wonderful note, I'm going to hand over to Andre. There may be a slide for you. No slide. I'm going to hand over to John, because now it's where you guys get to come in and play and get to know this tool and really start thinking from your vantage how you'll be using it. I don't know how to stop. Oh, thank you for stopping me. Great. Right.
John,
look at Amy's got a question. Amy, naughty Amy. You put a question in the chat and you didn't come off mic. So I'm going to answer this right now, if that's okay. She said, could you briefly clarify how H3 is different than MISP and the SPHERE guidelines? Well, I was involved in SPHERE, and SPHERE didn't take on the MISP as 5 standards. We kind of bundled it all into one because the board said we had to do that, and that's fine because coordination is considered a core humanitarian standard. It is not different, it's the same. We've mapped MISP and SPHERE into the H3. People from the IWAG, the MISP sub-working group from the IWAG were heavily involved in the development of the H3. And to be honest, they are the ones who gave the framework for what services from MISP should be provided at each level. John, I know there's a MISP revision currently ongoing, and so we are working with IWAG with ensuring MISP is updated, and there'll be a review process around that, and WHO and UNFPA and the IWAG are working on that. But I would say, the point is the service delivery platform. We don't have that anywhere. Andre, you have a response, I think, that may be better than the one I gave. Over to you.
Just to add on what the difference is with SPHERE and the H3, even though we harmonize things between all the the guidance that was out there on what minimum standards and services are. I think there's the difference with Sphere, EBA, is that Sphere was rights-based. It was written from the perspective of what should be available and what we commit ourselves. And I think in H3, we try to start from the bottom up. We try to say what is at minimum feasible and realistic, and what are the services that we should committing to. I think there was always a lot of concerns around Sphere that it was too ambitious, and that there was this concept of progressive realization. I think in H3 we try to define the starting point.
I'm just going to say, in the 2018 revision for Sphere, there was a very strong language that it must be the minimum, because I think they acknowledged the issues that everyone else had, Andre, around it. But it really is the fact that the H3 articulates very clearly, better than, oh, just make sure you're doing communicable diseases, or you're doing EPI, or you're doing this, where it should be done, and have a more practical approach with understanding the staffing, the medicines around it. Yeah, I'm going to leave it at that. But we tried. But we're going to hand over to John now. And I think, John, is this where everyone gets on their computers?
Yeah, if they want. This is great. Nice to be with you all. We are intending to make this really practical. And I know it's the end of the day for some people, but we want to have this really be engaging. Feel free to put comments into the chat. We'll pause periodically to have you provide feedback or questions. And again, we want this to be as useful as you can. We have created user accounts for all the people who registered for this session. So you will be able to log into the platform, and the platform is the Service Planning, Delivery, and Implementation, or SPDI platform. You can access it at uhcc.who.int here. And then we will make sure that you are able to log in. You should have received an email from Parisa, who's sitting next to me, and that will give you instructions on how to activate your account. If you're calling from a UN or WHO account, you will be able to have immediate access. So this is the landing page for the SPDI platform, and again, it's at uhcc.who.int. And at the landing page, you can learn more about the SPDI platform. If you want to refer colleagues or anything like that, there's a help section that can give you some access to videos. It's also where you can log in. And we'll go through this in about 20 minutes. I'm going to give you just a quick overview of how the platform works, and then we'll go through in more detail and allow you to follow along to understand how it works. Just so you know, the SPDI platform is available in 5 languages. So it's in English, Russian, French, Arabic, and Spanish. There are some requests for it to be translated into other languages as well. So just for some quick background about this platform, the SPDI platform, it was started about 4 or 5 years ago. WHO was receiving increasing requests to be able to support member states, to support countries in developing and, more importantly, implementing packages of services for universal health coverage. So more than 50 programs from across WHO. There's literally been several hundred focal points that have contributed to the database that underlies the SPDI platform. So there's literally millions of data points that not only define the services that are needed to deliver on UHC, but the resources that are required, delineation of the health workforce requirements, links to WHO references and WHO guidance. So there's a whole wealth of resources that are kind of in the back end here. And there's also links to the H3 package that Ibo was talking about. So the high priority health services for humanitarian response package. So that can be used as a reference. Let me just start here. I just want to, I'm going to show a couple of examples from some actual packages that were developed. So one package in particular, which was released this year, the Cox's Bazaar developed an H3 package, or a high priority health services package, for that setting. They convened a group of experts to look systematically at all health areas and then define the services that would be included in their package. They also considered prior packages that had been developed, and they developed a document which goes through and lists the various resources that would be required, just so you can get an idea of where we're headed. The services are defined at a high level, like, for example, services like prevention of HIV or management of HIV. And then they're mapped to context-specific delivery platforms. So in Cox's Bazaar, they had 4 delivery platforms. And again, every setting is different. Every country will have different delivery platforms. So making a package of services, making it contextualized for a given area is really important. So this shows in the Cox's Bazaar package, where there are services mapped to the community level, services mapped to the health post, to the primary healthcare clinics, PHC clinics, and to field hospitals. And so what we will be doing today, this is one potential output where you can see how the services are integrated across the health system. So let me just come back here to the platform. I'm going to show you how it works and how you might be able to develop, if you're interested, to be able to develop a package for your setting or to work with partners there. Just enter full screen here. In the upper right-hand corner of the SPDI platform, there's a login section, and we'll show you in just a little bit about how that works. So I'm going to just press login here. If you've already been to the SPDI platform, it should automatically take you there. The first time you log in, you may have to present your email that you used and then enter a password to allow you to access. Once you've logged in the upper right-hand corner is a section called My Projects, and that will give you access to your internal user account. Every country, every humanitarian partner can create a context-specific package, and you can create potentially a set of packages. So you may have, some countries have a package of services for a national UHC package, and they may have a humanitarian response package, or they may have a primary care package. And that can be delineated in the My Projects section. This is my dashboard, and it just gives you some sense of kind of the range of packages that are being developed. Countries are using the SPDI platform for many different use cases. So some countries like UAE are developing a national package of services for universal health coverage. Other countries and humanitarian partners are developing humanitarian response package. So, for example, I mentioned the Cox's Bazaar package. We worked in Ethiopia, and I'll show you some examples of the package that we developed with the partners in Ethiopia. Some countries are developing program-specific packages. So, for example, Jordan developed a package of services to address obesity. Many other countries did that similarly. So there's quite a number of different use cases for the platform. And again, for your purpose, it can be very useful to be able to define a package of services for humanitarian response. I'm going to go into, yeah, go ahead. I'll stop here.
Should I save questions, or can I ask?
You can come in. We make this entirely interactive, so please feel free to come in. Thanks for coming in. Over to you.
So 2 questions. One, who is able to create an account? Are there a limited number of accounts per a global health cluster partner? And two, I'm wondering if for each of these projects, are you able to have multiple users working on the same project, sort of like a shared, almost like a shared drive, like a SharePoint? Or is it, if I have this project under my projects, I am the only one who is able to access it? Let me know if that made sense or not.
No, that's great. So the platform itself can handle as many users as that want to access. Regarding a specific package, there should be a lead who's developing the package. So it may be the health cluster, it may be WHO, it may be the Ministry of Health that is designing the package. So there should be ideally one kind of common package. And then you can define, and I'll show you this, you can define different roles and privileges that different users have. So some might have an administrative capacity to define what delivery platforms there are. Others might only be able to comment or to review. Others might be able to edit and to add services. So there's different ways that you could bring in partners to be able to participate in it. And then the second question in terms of how to, I'm sorry, tell me your second question.
How many people per agency kind of thing? I don't think there's a limit.
There's not. We had in Kyrgyzstan, they were developing a national package. I think they had 75 people on one package. Not all of them could edit it. All of them could review it. So it really depends on your need. I think Myanmar had 75 people contributing to it. And again, not all of them were viewing the package at one time.
Fabulous.
Any other questions? Okay, I'm going to go.
That's me, John. Sorry if you don't see my hand.
I can't. I'm sorry. I can't see any hands.
That's
just from projecting. Go ahead.
That's fine. No, because I was reading the comment on the work that will be done on the mobile health clinics as a delivery platform. But just what were the thinking in terms of untraditional delivery platforms in humanitarian settings, and not just mobile health teams, but for example, you have other modality of quote unquote mobile teams. You have the teams that are they go and provide services in a non-functioning health facility, and then they stay there for a month, and then they move to another non-functioning health facility. So they are health facility, but the team and the nature of the service provision is mobile. We also have the rapid response teams. So they have a different bundle of services. They go when there is an opportunity, they provide the full, now thinking that probably they're not going to have another chance to come back. So they provide as much as they can with much of the time. They can stay there and then go out. So, or for example, the bundled of vaccination campaigns, along with 4 or 5 several intervention bundled together, and then as an opportunity where access is a problem, where we're not sure, we can have another opportunity to go in. Was there any consideration to those that's hard to define kind of delivery platforms, and how, or is the package itself require some specific definitions of delivery platforms? Thank you.
Absolutely. And again, the 5 delivery platforms that Eva showed were just default platforms. Every single country, every single humanitarian setting will need to contextualize the delivery platforms for that country or that setting. So I'll show you in the demonstration how to do that, and it can be done in real time. So, for example, we were previously supporting colleagues in Palestine to be able to define the delivery platform. So we worked with the Ministry of Health from Palestine to be able to define services for primary care. Even before the conflict, since the conflicts happened, they've needed to adjust the delivery platforms. But certainly there's the ability to contextualize. Let me hand over to Nurian, though, because we're also working to define the services that would be considered for mobile health teams, mobile health clinics. Over to you, Nurian. If she's here. Nurian, are you here?
Yes, I am here.
Okay.
I mean, in terms of the definition of mobile clinic, I mean, Ilham, as you rightly said, like there are very like different definitions or like way of defining mobile clinics by different partners, different countries. So based on the research findings, we have sort of recommending a definition here I put in the chat, and that is in line with the EMT like type 1 definitions they included in their like a strategy for, I think, 2030. So I included both in here. And again, for like the list of services can be safely delivered through mobile clinic. We are not saying that, you know, your mobile clinic is under the tree or under the tent or working from fixed health facility. So the services we define as a core in the mobile clinic package should be delivered regardless where the mobile clinic is operating from. I don't know if that answers your question, but please feel free to reach out. And we, of course, we will send you the, you know, invitation to join the expert validation process. Iba, over to you.
Yeah, just to reiterate and emphasize, Ilham actually, Save the Children did a year of research into mobile clinics with regards to what it looks like, exactly all those things you said. It can be anything and everything. It can be a community health worker plus, it can be a, you know, a MSF truck plus in doing surgery. So it was an iterative process. It had a technical advisory group. They had over 200 key informant interviews. It was phenomenal. It was huge. It was you looking at quality of care within mobile clinics. Many of you are involved. And from that, understanding that the common denominator is XYZ, we are taking that assumption for the H3, and then of course that has to be contextualized in every single setting. But this comes from a huge body of research that has already been done and is advancing from that. And yeah, you're right, it could be absolutely anything. Jorge Miranda was asking about PAHO countries. Yeah, so the health clusters in PAHO countries, so there's Haiti, there's Venezuela, there's Colombia, there's some others that I can't remember, Honduras. Honduras is probably deactivating soon, but Colombia is very interested, as is Venezuela. But we haven't launched anything with them. The health cluster coordinators have been trained. So we are happy to take this further, but to be honest, we are going full blaze ahead right now. But if you know, it's the health cluster, so we need to be responsive to health cluster partner demands. And so if there's a strong demand for this to be done soon, we can do this soon. I know they're already very eager, but we just haven't. There's so many competing things, but it's not a no, it's a yes, just when.
Thank you so much. Thank you so much. I would like just to add a few comments. In Necoclí, PAHO, the WHO, is leading the health cluster, and IOM, we have a mobile clinic in Necoclí. We are providing healthcare for migrant and host migrant population. But also, we are looking forward to for this tool, which seems very useful for because just to add a brief information, in 2023 there were 500,000 migrant population recorded passing through the Darien Gap region. So the need for services in the region is increasing, including not just to Colombia, but along the route in Darien and the rest of the region, Central America. Thank you.
Great. No, I like that. Thank you. Yeah, Colombia definitely with the migrants, the Venezuelan migrants, as well as the indigenous populations or the hard to reach areas within Colombia itself, it's in total it's about 14 million actually, but they're in two separate appeals, so people don't understand or realize the gravity of that situation. Yeah, okay, great. I'm going to talk to the health cluster coordinator after this. Prabhu, over to you. Hands up. Sorry, I know we want to move on, John, but Prabhu's got his hand up. If
Okay,
that's okay.
over to you. No problem.
Thanks, all. I just had a quick question to clarify the SPDI platform. I think it's very powerful. This is my first introduction to it. I just wanted to confirm that my understanding. So it looks like all the UHC services are available in this platform, and the platform allows local contexts to pull services and create packages of their own based on the full set of UHC services. And then the H3 package similarly is a subset of services from the full UHC package that are appropriate for humanitarian settings. Is that correct?
Yeah. Okay.
Great, thank you.
Workshop over, guys. That's it.
Prabhu, come join us. You said it perfectly. That's precisely what it could do. So that the SPDI platform has a comprehensive list of services allowing countries to contextualize for their capacity. So for example, we worked in Moldova, which I think it might be here. We worked with the ministry in Moldova to define a package of services for refugees, for Ukraine refugees. Again, not necessarily a humanitarian setting, but they used the H3 package, and they also were able to contextualize to the capacities in their health system. So every country, every humanitarian response will be different, so you can contextualize it. I'm going to jump back in here and show you some of the functionality, and then we'll go to kind of a play box to have you all experiment. I showed you the kind of the finished product, the printed version for Cox's Bazaar. This is the online version showing you how the humanitarian partners came together to be able to map services and to contextualize for their health system. The SPDI platform provides a structured architecture allowing partners and countries to go systematically through all health areas. So there's a section on foundations of care, so for emergency syndromes, sexual and reproductive health services, growth, development, and aging, a section on nutrition, for child health, NCDs and mental health, which are increasingly important in humanitarian settings, especially for protracted emergencies, violence and injury section, and a communicable diseases section. And again, really the structure allows for a systematic approach to considering all health areas. In the Cox's Bazaar package, I'm just going to go to this what's called a high-level view. So you can see one of the first things that they did is they went through kind of a high level. What areas did they want to include in their package? So they wanted to include services for emergency syndromes, services for common signs and symptoms. So those services that there may not be a diagnosis, but it's important to provide care and services for that. Reproductive and sexual health services. You can see they included some comprehensive services for that. Growth, development, and aging. And then they also started including services for NCDs, including for cardiovascular diseases, respiratory diseases, diabetes, thyroid disorders, a comprehensive suite of services for mental disorders. And then violence and injury, a comprehensive suite of services for injury, and then communicable diseases. So again, the platform is designed to support countries and partners in taking a structured approach to considering services. I'm going to go back to this, what we call an architecture view, just to give you an idea of how a country can go through those areas and to be able to map current service delivery, as well as to be able to consider what services that they might include in a package. Just for illustrative purposes, in the Cox's Bazaar package, I'm going to go into the foundations of care section. And the architecture of this is it's a nested architecture. So the further you go into the architecture, the more details you see about the specific services. So there's a section on approach to emergency syndromes, common signs and symptoms. Within the approach to emergency syndromes, you can see there are services for general approach to emergencies, difficulty in breathing, altered mental status, shock. Each one of these has increasing levels of detail. So as you open intervention, you will see increasing levels of detail. So in this example, general approach to emergency syndromes, early recognition of danger signs and illness with early referral. This is something that in the Cox Bazar package, they map that service to their context-specific delivery platforms. So on the right-hand side are the delivery platforms, and in Cox's Bazar, they had 4: community health services, health post, a primary care clinic, and then a field hospital or camp-level hospital. Again, this can be contextualized, and I'll show you specifically how that can be done for your humanitarian setting. Additionally, you can also see another function here. So countries and partners can use the tool to be able to define what services are currently being delivered. So in this case, point of care ultrasound is a service. You see the green dot here on the right-hand side for field hospital. That means selected. That's a service that was currently being delivered, but they recognize that they'd like to, ideally, be able to deliver a point of care ultrasound at primary care level if they had the resources available. So they called that an extended service. So the platform allows you to identify not only what services currently are being delivered, but what services potentially you'd like to add if you have, say, the health workforce trained, or you have the material resources, the products, the medicines to be able to deliver that service. Let me show you another example to show some more details. I'm going to go into the section non-communicable diseases, or NCDs, and mental health. And again, you see the nested architecture. So there's increasing levels of detail, and the UHC compendium architecture allows you to look at it in more detail to many areas, whether it be cancers or cardiovascular diseases, respiratory diseases. And as you go further into the architecture, you see more details. I'll show you an example for, say, diabetes. So in the compendium architecture, there are services for prevention, diagnosis, management of, say, hyperglycemic emergencies, longitudinal management of diabetes. And each action or each service can then be reviewed and considered as part of a package. Not all countries will consider, not all countries or partners will include all services in their package. This shows just an example of, say, you see that in Cox's Bazar for hyperglycemic emergencies, those services were mapped primarily at the primary care clinic and the field hospital, but they'd like to be able to add those services at the health post level if they had additional services. So they've called that an extended service. Similarly, for longitudinal management of diabetes, you can see those services also, say, oral medications or insulin, those are being offered at the primary care and the field hospital. They'd like to be able to do that at the health post level. Each service or action in the database has increasing levels of detail. The SPDI platform allows for linkages to the WHO's essential medicines list. There's also a medical devices database called Medivis, an in vitro diagnostics database called the Essential Diagnostics List. So when a country or partner is selecting a service for the package, it's also automatically linking to other detailed information that's important for implementation. I'll show you in a little bit how that links to emergency health kits. So what medications are included in an emergency health kit, and if that is included in a package, is it also included in an emergency health kit? There's also, here, I'll just show you an example. So you can see there's a link here to the essential medicines list. There's also links to WHO guidance, WHO references when they're available. So you can see links, for example, to WHO PEN. Again, some countries and some humanitarian partners, actually, they have their own guidance. So it is possible to do a custom reference. So countries have asked to be able to attach their own guidance specific for a humanitarian response. And so that's possible as well. Let me show you one other function here, and then maybe I'll pause for a second and see if there's some additional questions. So one of the valuable tools for the platform is the ability to be able to use reference packages. So Eva commented on the detailed work that was done over the course of more than a year to develop the H3 package, or the High Priority Health Services for Humanitarian Response package. So that can be used as a reference to allow countries to contextualize. It's also possible to look at countries' national packages. So if you're building a humanitarian response package and you want to see how it links to the national package, so kind of building that humanitarian development nexus, that's possible as well. So in this example, Cox's Bazar actually used a number of reference packages. So they used the H3 package, but they also looked at prior PHC packages that had been developed for Cox's Bazar. So by turning on that reference package, it's possible to see what services are in the H3 package and what services were in other prior packages. So for example, I've just turned on the reference package, and you can see in the H3 package, there's oral glucose solution for hypoglycemia. The partners in Cox's Bazar chose not to include that at the community level. They said they'd like to include it at the health post level, and it's currently being delivered at the primary care level. So the reference packages can be very useful. Again, it doesn't mean that a country will select all the services that are necessarily in the H3 package or assigning it to the delivery platform where it was mapped in the H3 package. Another feature here, you can see it's also possible to create custom actions. So I see in Cox's Bazar, they are providing insulin. So they want to make sure it was very clear that they had a service on counseling on insulin use, provision of syringes. Again, this can be really helpful for making sure that all the humanitarian partners that are delivering the services, that it's very clear on what services are being delivered, where they're being delivered, and making sure they have the capacity to be able to deliver those services. Again, whether it's capacity for health workforce or for the products or devices that are needed. Let me, maybe I'll just stop there and see if there's any questions right now, and then I can continue on and show you a couple of other examples.
Any questions? Are people fiddling around already? Or I've got one hand up because there's one camera on. Okay, I think we can go ahead. I think everyone's ready to play a bit, maybe. Yeah.
Great. I'm gonna just switch to a different package real quickly. I'm gonna switch to the Ethiopia package that we worked on with partners. And in August, about 70, 80 experts from across the country at subnational level came together to map the services for a humanitarian response package. And I want to show you a couple things that are relevant for the humanitarian response package in Ethiopia. I mentioned that, and Eva mentioned that it's important, it's really crucial that each country, each humanitarian setting is able to configure the package for their setting, for their country. And in the configuration section, you have the ability to define the delivery platforms. So in Ethiopia, for example, they chose 4 delivery platforms that would be included as part of their humanitarian response package. So a health post, a mobile health team, a health center, and a first level hospital. And so Nurian mentioned the mobile health team clinic reference package that is currently being developed. And Ethiopia was very active in defining the services for a mobile health team. Again, this can be contextualized. It also can be contextualized in real time. So we were working with colleagues in Gaza as the conditions changed on the ground there. They were needing to change and contextualize the delivery platforms. And I heard previously people on the call talking about the importance of being able to adjust in real time. And this is how you do it. I'll show you when we go through a walkthrough on how to do that. The other thing you can do in the configuration page, which is helpful, is in the reference package, you can define references, so reference filters. I showed you the example in Cox's Bazar. In Ethiopia, they actually used a number of reference packages. So they wanted to consider their national package, so the Essential Health Service package for the entire country that was developed in 2019, just to see what services were included in that package as they were considering the Humanitarian Response package. They also looked at the H3 package, and then they looked at the draft mobile clinic or mobile health team package that is being developed. So by turning on those references, then you can visualize those as you're selecting services. I'm going to go back to the package and show you just a couple of other examples. So this time I'll go into reproductive and sexual health and go into pregnancy and birth. So there's a number of services ranging from antenatal care, labor and childbirth care, abortion services, ectopic pregnancy. I'm going to go into antenatal care. And so there's services for routine care, management of antenatal complications. And here in Ethiopia, the Ethiopia example, you can see again the services on the left and then mapped to their context-specific delivery platforms. And you can see in this example, they wanted to add to the mobile health team services, say, oral medications for complications of pregnancy or hypertension, for insulin. And so they use this mapping to be able to define what services they could deliver right now, the green, and then they made what are called conditional services. So there's some issue, they don't have the products or the devices, or the health workforce hasn't been trained to be able to deliver the service. And then, let me see, I could show you a couple other things. So if I turn on the reference package, you can again see the reference filters here. You can see in the H3 package what services were there. So you can turn on this reference filter when you're doing it. There's a couple of other things that people ask about. There's a filter function, so you can actually filter the services by, say, type of care. So if you want to see, we were working in Sierra Leone and they wanted to see only the services for surgeries because they were building the capacity of surgical services at the first level hospital. You can also do filter by palliative care services or rehabilitation, if you like. There's also filters by delivery platforms. So for example, Gaza at one time, they only wanted to see the services that were at the primary care level. Again, it allows you different ways to visualize the data. Let me stop there, and then I'm going to show you the export function, and then we'll move on to the playground to
Great. John, can you just pop it on the filter again? And just to highlight that on the filter box, add filter. Oh, I don't know.
Yeah. So you can add, once you do here, you can select add filter.
Right. So if you've got, and this comes up a lot, and so I'm just going to knock this on the head straight away with regards to child healthcare. We've already showed that you can do IMNCI as a reference package, but you can also filter out all the services that are relevant to the different life stages. So if we go to the life stage, great, you can filter out by newborn, by very young, early childhood, and then later. And so that allows for child health to be looked at. I think one of our issues was, number one, children don't stop being children at the age of 5. And they still face high risks. They're still getting malaria, whether they're 7 or 8. Likewise, mental health services, other services were critical. So that's why we've integrated it there. But to be able to understand exactly the full spectrum of child health services beyond IMNCI, for example, you have that ability there. Just wanted to highlight that.
Great. Thanks, thanks, Eva. So let me show you some of the export functions that I think can be very helpful, and I'll show you some different ways that countries have been using it. So in the upper right-hand corner, after you've mapped services, you're able to export. There's a variety of different exports that are possible. So you can export the package details, meaning what services have been selected, what delivery platforms have those services been mapped to. You can then be able to define a lot of the details about the medicines, the products that are needed to be able to implement those services. So there's a variety of different things that can be done. You also can do a comparison. So if you want to say, compare your package to the H3 package, which is what Moldova had done when they developed their package of services for refugees, Ukraine refugees. They wanted to see, how did we do compared to the H3 package? So there's a variety of different exports. There's also the ability to export resources or medicines, products, kits, sets, IVDs, again, helping you to be able to define the material resource requirements that are needed to implement the package, and to be able to see where you might have gaps. Also potentially to see what's being included in an emergency health kit that might be useful. Let me just show you a couple of examples of the exports. I will show you here. This is the Cox's Bazar package that I had exported previously. And one of the standard exports is an Excel file, and you can see here on the left-hand side, so services for management of extremity injury, management of wounds, and then the specific actions or services listed here in column H, and then mapped to the context-specific delivery platform. So what services are being currently delivered, where are there gaps? So you can see, for example, in Cox's Bazar, they were wanting to add services for management of extremity injury, but they didn't currently have the capacity to be able to do that. So it allows for kind of a review of what services have been mapped, and it also can be useful for delineating to partners, what are they partners responsible for, and it can be helpful for contracting accountability. There's also additional information, and this can be used. Some countries have used these exports for costing. So there's information about the health workers that are delivering the services. There's links to the medicines that are required, links to the diagnostics, and then other information. So links to WHO references when it's relevant. Links to the Sustainable Development Goals for reporting and things like that. Let me show you one other export. So it's also possible to export the medicines, the products, and the lab test or diagnostics that are needed to be able to implement a package. There's a module that allows for countries to be able to input their national formulary or local formulary that would be used to be able to map it to the services that were included in the package. This was actually some work that we just did in the last week with Gaza. So we imported the 2022 OPT formulary into the SPDI platform, and then we looked at the services that had been selected as part of their package for mobile health teams, for health centers, first referral level hospitals. And then we also mapped it to the emergency health kits. So you can see in column C what medicines were part of their national formulary, and then where were those services mapped. So over here, you can see these services were mapped to the hospital level. Some other services like medicines like ibuprofen, paracetamol mapped to the primary care level. But you can also see what are those where are those medicines available in other health kits, so emergency health kits. So you can see that what's in other emergency health kits if you have access to those. So this can be a useful output that allows you to define the medicines that are required. Where are those medicines required? Are they available in emergency health kits? And are they included in, say, a national formulary or local formulary that has already been devised? There's also links to product and kits, sets, modules that might be needed. So what are the specific products that might be needed to be able to deliver those services? And these are linked to WHO databases. So for example, Metavis is a very powerful database being developed by WHO, which has detailed lists of services and products in the Metavis database. And then also lastly for lab tests, so defining specifically the IVDs, the in vitro diagnostics or point of care testing that has been assigned as part of the package. So let me stop there and see what questions you have, and then we can move over to the playground. Okay.
There's a question in the chat, I believe.
Okay, so the question is, are these locally defined packages accessible only to those who have admin privileges? So I'm not sure, maybe just come in. I'm not sure exactly what you mean.
Will anyone be able to look at Cox's Bazar or Ethiopia?
If the partners give permission, again, it's not publicly available right now, but if there's an agreement to be able to share access, that would be possible. The other thing is to be able to use that as a reference if the partners agree in the different areas. So for example, looking at Moldova or Ethiopia or Gaza. Yeah.
And John, just the reason I asked that question is for organizations that are doing supply donations or procurement for local health systems, it would be helpful to know for them what medicines and supplies are locally approved by the ministry. And then also for EMTs that may be coming into a local context to interface with the existing health system and work alongside them, knowing what the local health system is using, that'll allow them to better integrate in that environment.
Yeah, that's I think a really great use case. I think it'd be necessary to contextualize some of the exports, the outputs specifically to do that. Certainly could work to devise that and making it clear what specific products are needed at different levels of the health system.
Gabriele?
Yeah, just reacting. I think it's good to, if we don't have the information through the platform here, it's just to ask the Ministry of Health the essential drug list. So the EDL of the countries to know which molecules are accepted or not for importation for use according to the national protocol. Over.
Yeah, I think that's what they just did for Gaza. So, although that has lots of barriers around importation, of course, but yeah, John, about you can bring in the national medical drugs list.
Yeah, there's a medicines module which is now available, which allows a country to be able to import their own formulary. So you can define what's in their national formulary. They can add custom medicines if they have additional medicines that are available. So it allows you to be able to harmonize the services that have been selected with the medicines that are in the national formularies or other subnational formularies that might be available. We will be working on, in the coming few months, a similar module for products, so defining specifically the material resources that are required, including the diagnostics. Currently, that module is not live in the SPDI platform, but it's coming. We have links to, as I mentioned, to WHO reference databases, so the essential medicines list, the medical devices database, Medivis, the medical PACS database called MetaPACS, and the essential diagnostics list, or EDL, as well as links to WHO IRIS database, the references. So you have links to the WHO guidance documents as well. So that module for the products will be coming. It's not currently available.
Cecilia from MTI has a question. Feel free to go on mic, off mute. Cecilia.
Hi. Yes, I'm just thinking, for the whole process to get approved in the platform, it may happen that for some reason those programs maybe even shrink or maybe expand in the process. So for how long this all these packages will be in the platform once they are approved?
Well, especially for humanitarian response, the packages can and should be contextualized for the current conditions. I go back to the example with our colleagues from the West Bank and Gaza. We had actually done a work with the Ministry of Health from both Gaza and West Bank in September of 2023, before the current conflict. And so they had defined a package of services. They'd done a preliminary package for their for both West Bank and Gaza. Conflict happened, and now they're contextualizing. They need to obviously contextualize the delivery platforms for the current context. So it can be very fluid and can change. And the platform allows you to be able to modify the delivery platforms and to even modify the services. Similarly, ongoing and upcoming work in Sudan, where the delivery platforms are changing. They're different between at the subnational level. So it's possible to modify those over time.
But Cecilia, you can export. So, you don't have to keep it on the platform. You can export everything as an Excel sheet, as whatever, as a PDF, in those different ways. So however you want it. If the website goes down, you will you still should have access to anything that you've downloaded. Anyway,
thank you.
Andre, you had your hand up, which is so weird.
Yeah, but I don't want to talk too much. So I think there's two things that I just want to add. If together with the local health authorities and partners, you agree on a high priority package for your particular context, then that is fairly robust. And even if funding goes down, that reference as a standard, that remains relevant. So if there's an escalation in the humanitarian needs and there would be more funding, that reference still remains valid and useful. Now, I think in general, packages need to be reviewed and updated at least every 3-4 years, because there will be differences in treatment protocols, and the resources may increase over time. So the package itself is not static, but it doesn't lose its value when funding goes down. That's just what I wanted to say.
I mean, in fact, when we were working with health cluster coordinators, they were quite excited because it clearly shows where they don't have money to do X, Y, Z services that they think should be done. That has collectively been agreed on, and it's a key advocacy point as well. It's like, well, we should be doing this. This is minimum as us, and we could do it, but we don't have the funds for that. So it's a powerful tool for advocacy as well. John, it's 5 to 5 and we finish at 5:30. So I'm eager to get everyone. I don't know if people are playing as John's been going on, but I'm eager to help.
Go ahead. So let's jump in. all of you should have, if you signed up, Parisa very kindly has created a package or an online account for you. So you should be able to log in. And you can go in the upper right-hand corner, you should see login. The first time you log in, you will be asked to give the email that you provided when you signed up for this session. And then the first time you sign up, or the first time you log in, you'll be asked to enter a password. And so you should see an email that says Microsoft invitations on behalf of the World Health Organization. And it came probably on Friday, December 6th. And you may see Kamali Parisa has invited you to access applications. It looks like spam. It's not. it's actually inviting you. So anybody having trouble going to log in? And if you are, then go ahead and type into the chat. Otherwise, once you've logged in the upper right-hand corner, you'll see my projects.
I'm hoping they've already been playing while you've been presenting.
Right, good. So you can go to my projects, and then we're going to say new. And maybe you've already created a new. So let me just go back here. I'm just going to go back. Is everybody here on it should say my projects. You probably will not have any projects. It may be blank. And then in the upper right-hand corner, you can see new. So go ahead and press new, and we're going to create a package. So I'm going to, if you can, please call your package H3-test.
I'm going to join in.
Dash your name. So John Fogarty. And the reason why is that way we'll know where it came from. And if you're not using it, then we're able to sort them. So this is a country package. It's not a global reference package. And I'm going to make mine for Switzerland. And then prior package. So I'm going to use the H3 package as my prior package, and that will turn on the reference here. And then I'm going to say finish. And this will create kind of the template. It won't have any services in it. It won't have any interventions that have been selected. And it defaults automatically to those 5 delivery platforms that we were talking about. So it defaults to a community platform, a pre-hospital services, outpatient, first referral, and second referral level hospital. And then I will show you how to contextualize for a delivery platform.
I've got the Mr. Wheel going around still. Not sure if that's what everyone else has got.
It may be
too many people.
It may be that there's a lot of people on right now, which is cool. All right. So soon you should see it should reset. And you'll be back here at the package configuration page. On the left-hand side, you'll see a number of different options for configuration. We're just going to do one thing here. We're going to add a reference package. So at the reference package, I'm going to add a global reference package. So I'm going to add the H3 package.
Can we just do that?
Yeah.
Learning as well.
Sorry, you know what happened? Actually, it's kind of cool. You were going to get automatically default all the services that are in the H3 package, because when we started with the H3 package.
Yeah.
So we'll see. You'll be able to see it. So these are the delivery platforms in the H3 package. So community-based services, outpatient, a dedicated pregnancy and birth center, first level hospital, and a second level hospital. I'm going to say finish. And that's the reason why it took so long, because what it was doing was actually importing all the services from the H3 package. So now you can actually see what is in the H3 package, and it'll be in yours. So I'm back to the package selection. So you'll see up here the number of options, package, medicines, configuration, and then you're on the what's called the architecture view. So you'll see the structured architecture here on the left. On the right are the services that have been included. You'll see this is a what we call a progress indicator bar. So what services have been included, and you can see what areas where there have been services. Because I put in the starting point of the H3 package, it pulled in all of those services in the H3 package as a starting point. Now, you may not want to do that for your package if you're developing a humanitarian response package for your setting, but it'll show you illustratively what services are included. So we can go navigate here. Let's go into communicable diseases, which we haven't seen so much. So I'm going to press on communicable diseases. And then you'll see there's services for communicable disease prevention, NTDs, and then other communicable diseases. So I press on communicable diseases. You can see services for HIV, TB, malaria, lower respiratory infections. So you can go in lower respiratory infections, and you can see there's services for prevention, screening and diagnosis, management of acute lower respiratory infections. And you can see what's included in the H3 package here, because those services have already been mapped to the delivery platform. I'm going to turn on the reference package just so you can see also as a reference what's in the H3 package. Now, if you were to start out with the H3 package as kind of a starting point, you can then obviously contextualize it. So let's say, for example, in your humanitarian response package, you would be systematically going through all of these services, and you say, well, we actually have inhaled bronchodilators not at the outpatient, but we also have those, say, at the community level. And so you can select that. You can select the button, or you have oral antimicrobials at the community level. But you don't have inhaled beta agonists at the outpatient level. You only have those at the hospital level, as an example. So you can deselect the service. You could say, well, intramuscular antimicrobials, we have those at the outpatient level, but we'd like to even be able to do that at the community level. So I'm going to call that an extended service. So we'd like to add that. So you're able to add on select services based on your context-specific needs. And you can then be able to also contextualize the delivery platforms. And I'll show you how to do that in just a moment. So this is how you select services. We have in the SPDI platform, there are 3 kind of designations for options for selecting services. So for example, if you select here, if you hover over a radio button, you can see 3 dots. And if you select that, you can see I can choose a service that's selected, meaning a service that should be and is being delivered at that level. Or conditional service. Conditional services, the way countries have used this frequently, is to define those services where there's some bottleneck or gap. They should be delivering that service, but there's some reason why they can't. Maybe the health workforce isn't trained, or they don't have the material resources to be able to deliver that service. And so it can be very useful in being able to identify where there's gaps or problems or bottlenecks in service delivery. And similarly, you can also select what's called an extended service. The H3 package uses extended services to define those services where they definitely don't have the capacity right now to be able to deliver the service. They'd like to in the future, but they need to train the workforce, or they need to add additional material resources to be able to do that. So let me stop there. I think many of you are playing on it. I think there's a question in the chat which says that you can't see the workforce module. That is currently in development. We are working with a number of partners to do testing of the health workforce module. If it's something where you would like to be able to test, if you'd like to be able to use the workforce module to define the capacities and the competencies for the health workers delivering those services, we would be very happy to work with you. But the health workforce module, what it does is allows you to be able to go into all the different areas that all the services that have been selected, and then be able to determine whether you have the health workers to be able to deliver those services. Let me see if there's other questions right now.
John, I have a question.
Okay.
So I set up a sort of test package, and I'm seeing, I just chose to reference packages sort of randomly. And when I'm going into the package to configure the different services, it looks like I can toggle on or off reference packages, and it will have a blue underline under some service delivery platforms.
Yeah.
Is that like a recommended per that reference package, or what exactly does that mean?
So that's a great question. Thanks for asking that. So in the H3 package, there are in reference packages, they are typically not only a list of services, but those services mapped to a delivery platform. So you can see when you turn on that reference, you can see what services currently are part of that package and where those services were being mapped. So I'm just going to go into contraception and family planning as an example. I'm going to turn on the filter, the reference packages. So in this example, I only turned on the H3 package, and you can see what services were part of the H3 package. The little blue dash underneath the delivery platform means that service was included in that reference package. And then the colors, you can see what colors. So for example, oral hormonal contraceptives are part of the H3 package, and they're considered a core service or a green selection. Here, female condoms are not part of the H3 package, but they were considered an extended service. If you had the capacity, if you have the resources, you could consider adding that service. The ones that are blank, so you can see diaphragm was not part of the H3 package, whereas IUD was part of the H3 package, or tubal ligation was part of the H3 package.
And so the idea is that the H3 package has mapped this intervention also to the service delivery platform, and whether or not it's core or conditional. So male condoms are considered core at the community health worker level.
Exactly.
Okay.
But that, again, this is a reference, and you don't, every country, every humanitarian setting is going to need to contextualize. So for example, if you don't have the capacity to do an IUD at the outpatient level, you would deselect that. And you say, well, we can only provide that right now at the first referral level. We'd like to be able to do this at the outpatient level, but we don't have the capacity right now. So we're going to call that actually an extended service. We need to get the products or devices to be able to do that. So you would use it to contextualize. Again, the H3 package is designed as a reference. It's not guidelines, and it always needs to be contextualized. I'm going to go into the configuration page just to show you how.
If I may add one thing, John, sorry.
Yeah, please go ahead, Nuria. Over to you.
So if a specific service is highlighted as a core at the community level, that means it should be also core at the primary healthcare level, first level referral, second level referral, just to clarify that. Over.
Yeah, the great question. Thanks for bringing that up. So the H3 package defined basically a minimum delivery platform where you might consider adding a service, but didn't say you can do it everywhere else. It was assumed that if a service is available at one level, it could be delivered at all levels above it. So for example, in contraception and family planning, it would be considered that oral contraceptives would be available at the outpatient, but also at birthing center, first referral level hospital, second referral. Now, some countries say specifically, well, we don't necessarily want to prioritize delivering a certain service at, say, the hospital level. We want to try to push those services to lower levels of the health system. So they might say, well, we're only going to do oral emergency contraceptives at the outpatient and at dedicated birthing facility, for example. It doesn't, maybe that's not a great example, but you can define clearly what services you want to provide at different levels of the health system. So
Andre's politely got his hand up, and then actually Sumaya had a question in the chat box, which she did ask, and I didn't really, it sounded very clever, so I kind of avoided it. So we'll go to her afterwards. So Andre, to you, and then we'll go to Sumaya, if that's okay.
Yeah, indeed, following what John said, I think some countries that we work with, we just defined it at the lowest level where it should be available. But there are countries where they feel it's helpful that if that service is also given at a higher level, that they also make it green there. But there's some services at community level that you would not see in an outpatient or a hospital. So there's some services that are, in this case, very specific to community platforms like screening and community-based services that you would not have at an OPD, simply because the health workers have a different job description. But so that's how you can play with it.
Sumaya, you had a question, which was, can we use this? Oh, well, you can say it. I don't need to read it.
Sorry, thank you. Yes. Very interesting. My question is to know if it's possible to use this package when you have, for example, a project on the humanitarian, to contextualize anytime the involving situation in the dashboard, for example, and to have the continual situation in our countries.
So do you mean like using it as a monitoring tool to see what services are available?
Mm-hmm.
Yeah, that's our next question. That's our next brain. John's got ideas.
It certainly could be used. That we had some preliminary discussions with colleagues in Sudan about that, where it wasn't clear what services were available in different parts of the country. So potentially it could be, and also looking at what services continue to be delivered. So it wasn't, as Iba had commented in the beginning, this was designed originally for protracted emergencies, but we're finding that it could be useful in an acute emergency.
I mean, you're right, Sumaya. I mean, and that's, we wrote at the beginning, ideally we'd want to be monitoring the services that we've all agreed to deliver. And so we have tools like HERAMS that are in some contexts, or other kind of service mapping in health cluster. And, you know, service mapping is a minimum information service we're meant to deliver in a cluster. And so, yeah, we haven't got there yet, but that's what we would like to see, and we would like to develop tools around this or advance this. Is we've defined these services, what are we actually able to deliver against it? Have we been able to do all the things that we've collectively agreed should be done? And what are the barriers for that? Is it funding? Is it access? Is it insecurity? And then use the advocacy around that. And so the monitoring side of it is the next step of how we want to go. Although we're not there yet, but we want to. And it should seamlessly, where HERAMS comes in, work with HERAMS where that exists. But no, you're completely right.
Hey, but I just want to comment on one of the security functions with the platform is that this is operated through the WHO server, and there's the Azure security system. So if you haven't selected a service, if you haven't done something for about 10 minutes or so, it will log you out. Now it saves your work continually. You don't have to keep saving, but you may have to log back in if it logs you out. So I'm just going to go back in, and I'm going to find my test package. Go back in. All right. So let's see. There's another question about Prabhu. Let me just go over to you. I think you had a question about health workforce. Sorry, I can't see the chat very easily. Go ahead.
Thanks, John. I'll try to make it quick. We had mentioned earlier about how with the H3 package, the OPT level would be primarily nurses, where the COM level would be community health workers. But I see a lot of primary care services like diabetes, anti-hyperglycemic treatment would be provided at the OPT level. So is the assumption there or the recommendation there that the OPT level without doctors would be doing a lot of these primary care functions? If that's the case, I fully support that. I'm just asking, is that the recommendation from WHO with regard to the H3 package?
I wouldn't say it's WHO. Well, we would say it's a consultative, as it's a guidance, it's a reference package. It used the NCDs in emergencies experts across all the different providers, whether it was WHO, Slim Salama, as well as Kieran, blah, 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 and the whole NCDs batch. So yeah, we were guided by them and what they would expect. So it's in line with existing guidance that they've been either writing themselves or pushing for or advocating. We had those hard conversations. And yeah, it's hard to say WHO is recommending this. It's a consultative process and it's agreed on that. There's a lot of evidence missing, to be honest, with regards to task shifting, with regards to humanitarian response, with regards to costing, etc., etc. And we found that in the research phase of this. And so this is why it's a guidance rather than a guideline. It's a reference package rather than otherwise, but it's in line with all the other packages that are out there. So it shouldn't be at odds. It is not at odds with other guidance that exists. I'm trying to deflect because that was.
No, it's. I think, and it always needs to be contextualized. So it would be ideal that there would be services for longitudinal management of hypertension at the outpatient level, but some countries may not be able to do that, and so, or in a given response, so that might become an extended service, and you're just sliding the services to where that service can be delivered. So again, the purpose really is to provide a reference, but it always needs to be contextualized for the given situation and the capacity of the health workers. In Gaza, where they had a very well-trained workforce, for example, they were providing services that were far at lower levels of the health system than the H3 package. Same with Moldova as an example.
John, just saying we've got 11 minutes left. Ilham has a question which I'd like to.
It's actually 2 points, so I'm a bit greedy here, Iba, and thank you so much, colleagues. This is really rich. So a couple of points / questions. So obviously the flexibility that are needed for humanitarian settings is built in the design of that package and in the process of selecting it, agreeing on it, and so on, and that they are rooms for when the access improves or worsens, when funding improves or worsens, or when you have better training of health workers, etc. But how do you ensure that when the discussion about the H3 is coming up, because any of this has come up, that this gets in the institutional memory of what has happened before, that this doesn't go to, question the fundamentals of the work and so on. I'm just imagining the realities of how that work and with institutional memory, where people change and things change very quickly. And the other one, which is related to it as well, is obviously this is for the cluster partners, but and you made a reference to the basic package of the government. That's also can be a reference and so on. But how do you see the role of governments, because sometimes in certain clusters, hybrid clusters / sector, subnational level, there's certain influence of governments, and it's not the same. So how do you see the way government can come and say, no, this service is absolutely needed at that level and it should be there because in our basic package 5 years ago we have included this? I mean, how do you manage that aspect of certain governments that we know we deal with, that they come in and become heavy-handed on choices that partners do based on realities and things that they really understand and can have control over?
This is a great question. Andre's going to come in, and so will Norian and John, as they've actually also worked in Ethiopia on this. But this is our job, right, as health clusters and as WHO as cluster lead agency. It's our job to have those hard conversations. It's our job to bring everyone to the table and have that dialogue. In some cases it works fine, and in other cases it blows up. But that's humanitarian diplomacy no matter what. Whether it's defining an essential package, this package, whether it's just trying to get access, or whether it's just salary negotiations, humanitarian negotiation, diplomacy is part of our work. And it really is the role of Health Cluster and WHO to bring that all together. I mean, we're there in support of national authorities, so we do our best to keep them there. So Cox's Bazar, Ethiopia, Myanmar, where it was all done, it was all with the Ministry of Health at the table having those discussions. And Myanmar's not easy. Ethiopia is not necessarily easy either, but there was big participation. And so, we can. John's got a little. I'm going to look for it. A little agenda setting thing on how we do the workshops, but it's not a unilateral thing. It's the health cluster's role is to support humanitarian response, bring everyone together, but we all have made commitments around quality. We've all made commitments around AAP, to do no harm, to do our best, to do safe care, and then to do not just one bit of care, but which is inequitable, but to be clear on what we can provide. So we have made commitments as humanitarian partners as well. And then, those negotiations, those conversations are tough, super tough. And so I'm going to hand over to Andre, and he can bring some life experience from the Ethiopia tough negotiations that happened. And meanwhile, I'll look for that thing that you developed, John.
Yeah, thanks. Just to, if local authorities or ministries of health push for things that we think are not feasible or realistic, there's a few things that we can use as arguments to push back or say, listen, it's great to have these ambitions, but currently the drugs to do this are not in the essential humanitarian kits, for example, or if it's something that is currently not a tradition of being provided in that context, then it's simply not feasible to introduce it, and it may require some additional training or more resources to add that particular service. And I think this is where you can use this classification of conditional, that you can park a few things in there that you can acknowledge the fact that the service as in and by itself, it's good to add, but that currently is not yet feasible, realistic to make it available to everybody at this particular point in time. So the country workshops that we do to help adapt H3 to the local context, it starts with discussions within groups that should reflect on what is currently feasible, what is currently being delivered in the facilities that we support. And it's not only MOH that can push for more ambitious services or drugs to be added. We had a group on one of the components of the package. Unfortunately, there were no partners in that group who were actually delivering those services. So I think one or two of the groups also started adding some services that are probably too ambitious and not realistic. And that's why for Ethiopia, we need a last round of reality check with some partners before we can finalize it.
Guys, we're coming up to 5 minutes to the end. We're happy to stay on, but I'm sure you're all happy to go. I've got my coffee with me. So if there are questions, or John, did you have anything else you wanted to show or walk through?
Nope, that's good. Again, we would be very happy if there are partners that want to do an intensive training for people in your setting. Happy to organize a kind of a deeper dive on how to use the platform and to be able to contextualize it for your situation. We'll send out, as Eva mentioned, we can send out a short document about how you might consider doing it's a quick guide to developing some workshops to be able to define a package. So we'll be sending that out, but happy to answer any other questions or do another more detailed presentation at another time. Thanks everyone for staying on.
Great. So that guide is in the chat. We can send it out as well. We do have 2 wrap-up slides, but I think John's just come up with something much better. Andre, I'm not sure if you want to do your wrap-up slides.
No, it's good. We can make the slides available. It's just some messages that you can also find in the guidance that once you have your package defined and adapted, that's not where the work ends. That's actually when the work starts. So this is when the cluster, the partners, the ministry, all partners need to work on implementing it and adding all these other components that we already touched on briefly. So we'll make the slides available, but just to not forget that the work is not done once you designed your package.
Yeah. And so, yeah, just a reminder, I would say it's a tool that's useful for you as an individual agency, regardless of whether there's a cluster or not. In your work, it's a good way of seeing where you are, your stop checks against that. But then as the cluster, and my request as a health cluster is that you're all part of the health cluster. You're all health cluster partners. So if you think it is something that needs to be driven in one country, we are here to help support that. Sometimes health cluster coordinators just are absolutely overwhelmed and it's just very hard, but it's, you know, it's a collaborative process. It's a small group. We can support that. Reach out to us if you think this context really needs it, or for my organization, we really need support. Just like John said, we're happy to support in any way. We are, you know, again, reiterating, this is completely linked to AAP and our accountability to be able to provide appropriate quality response for our populations. So thank you for joining. Feel free, I've forgotten what my email is, or the health cluster email. If you want to ask any questions, reach out. What is it? healthcluster@who.int. Email us with anything that you want. I will carry on talking unless someone says thank you. Goodbye. Thank you. Okay.
Thank you. Bye-bye.
Thank you. Bye.
Bye, everybody. Thank you.
Take care, everyone.
Thank you.
Thanks, John.